Um, just quickly, a brief overview of what we've done in the last year here at Zero. I want to share 3 points with you. One is dating about a year ago, we set up a group called our Racial Disparities Task Force that brings together the perspectives of clinicians, patients, caretakers, and those who have lost a loved one to prostate cancer within communities of color to focus on the disproportionate impact of prostate cancer on racial and ethnic communities. We also, back in June, hosted our Racial Disparities Symposium. It was our inaugural Racial Disparity Symposium. As I said, it took place in June. And it was a half-day event that offered presentations and discussions about the causes, impacts of, and potential solutions that we can rally around to overcome inequity in healthcare outcomes for African American men who are facing prostate cancer in the United States. And then finally, I'm happy to announce that within the last month, during Prostate Cancer Awareness Month, we've launched a new internet resource focusing on addressing racial disparities in prostate cancer. And it's on the Zero website if you go to zerocancer.org/racial disparities. And now I'd like to introduce 3 amazing colleagues, 3 amazing men I have joining me this morning. First up, we have Robert Ginyard, who is Zero's chairman of the board, also the co-chair of our Racial Disparities Task Force. He's a prostate cancer survivor and entrepreneur. Hey, Robert.
Hey, good morning. Glad to be here.
And Dr. Kelvin Moses, who's an associate professor of urology at Vanderbilt University Medical Center, and he's a member of Zero's board of directors and Zero's medical advisory board, and co-chairs with Robert our Racial Disparities Task Force. Hey, Kelvin. Hey, Dr. Moses. How are you?
Good morning. Good to be here.
Excellent. And then finally, I want to introduce Zero's Vice President of Health Equity, Dr. Reggie Tucker-Seeley. Hey, Reggie. How are you this morning?
Hi, Jamie. I'm doing well. Good morning, everyone. Greetings from Los Angeles.
Good morning.
Great. So we're going to have a format around having a town hall where it's going to be a conversation among the 4 of us that we can ask each other some questions, have a great discussion, and then we're going to save some time at the end to answer some questions and get some comments from some of the participants, some of the attendees. And with that, Reggie, I'll turn it over to you.
Great. Thank you, Jamie, for that great introduction and providing a little bit of context for some of the efforts that Zero has been working on in the area of racial disparities. I'd like to start by asking Dr. Moses to highlight some of the disparities in prostate cancer, which showcase why Zero is focusing on racial and ethnic disparities in prostate cancer. Dr. Moses?
Thank you, Reggie, and thank you to Zero and the leadership for prioritizing such an important topic. The reason why the task force came about and why we're so concerned about it is that there have been stark differences between Black men and white men in the United States when it comes to survival and diagnosis of prostate cancer. Overall, Black men in the United States have the highest incidence of prostate cancer, and that's even compared to Black men in the Caribbean and even our Western African brothers. Black men are much more likely to be diagnosed with higher risk and higher stage disease. And as Jamie mentioned earlier, we have greater than twice the risk of death from prostate cancer compared to white men in the US. And this has been consistent over several decades when we look at what's called SEER, or the Surveillance, Epidemiology, and End Results data, which captures about 10% of the population. We've seen this gap very consistently. And even in the era of PSA screening starting in the early 90s, even though there was a decline in death in both races, that gap still persisted. Although there may be minor contribution of genetic or biological differences, the difference is really driven by, number one, Black men are less likely to receive screening for prostate cancer. and less likely to get treated for prostate cancer. And this is driven by how African Americans in this country interact with the healthcare system, namely differences due to lack of access, and that could be due to insurance, could be due to just systemic racial and ethnic attitudes that are within medicine that mirror the greater society. What we see happening in the news and education and law enforcement and neighborhood policing, it's the same thing that happens in medicine. And so these differences that we see are ingrained. And so we have to attack these ingrained problems in order to see an improvement in the disparities that we see in prostate cancer. And what we see in prostate cancer is mirrored in colon cancer, breast cancer, diabetes, hypertension. And so we have to realize that what's happening in prostate cancer is not occurring in a vacuum. And so that's the point of this task force. We wanted to come together to identify some of the critical areas where ZERO can help address some of these issues. And I'm glad that Dr. Tucker-Seeley has been brought on board, and he'll go into more in depth about what his role is and background. But that's why we exist, and those are the things that we are focusing on.
Great. Thank you, Dr. Moses, for giving us a bit of the context to help us better understand why ZERO is focusing on racial and ethnic disparities. So now I'd like to turn to Robert and Jamie. So as chair of the board, Robert, and as president and CEO, Jamie, this position at ZERO is new. So my role is new. However, a focus on racial and ethnic disparities, as Jamie mentioned at the beginning, is not new for ZERO. And I know that there have been efforts that Jamie described at the beginning. Can you all describe in a bit more detail some of those efforts for our audience, in particular highlighting the Prostate Cancer Symposium, or the Racial and Ethnic Disparities in Prostate Cancer Symposium? I think you both are on mute.
Robert, do you want to go first? Since
Well, yeah, I was going to chime in that, Dr. Seeley, you brought up a wonderful point in that, this is dealing with the health disparities issue is nothing new for ZERO. I recall becoming involved in the organization in 2013. And even at that time, we were always cognizant of what the disparities were between white and Black men. And, we had made an effort and continue to make an effort to bridge that gap. And, one of the things that I always look at in terms of addressing this disparity issue, it really is about relationships and not so much a color issue. One of the perfect example, a gentleman by the name of Phil Shulker, who works with ZERO and helping us with some of the Run Walk series, and a very good friend. And he and I used to travel the town of Baltimore spreading the word about prostate cancer. Now, Phil is a white gentleman, and we were commonly known as Ebony and Ivory out on the circuit. And so it's about relationships. And I know Phil, given our relationship, he would want the best for me as an African American, and as an African American, I would want the best for Phil. So, it really is about bridging this gap to create long-lasting friendships and to make sure that no matter what color you are, you're healthy enough that you can enjoy time with your family, time with friends. And so again, ZERO has always been trying to address this point. And I'd say for the past several years, we've been very successful at doing that.
Great, Robert. I love that. I love the story. Ebony and Ivory. I knew you could play the drums, but I didn't know you could play the piano too. That is great, and it's a beautiful way to look at it. Specifically, yes, Reggie. Yeah, we've always been dedicated to trying to wipe out racial disparities within prostate cancer. Some of the specifics with that is, for years, we had mobile testing units that were like these RVs that were designed specifically to do prostate cancer testing. And we would zigzag those across the country. And more often than not, we would partner with places like Church of God in Christ, 100 Black Men of America, Congressional Black Caucus, to be able to bring those vehicles into communities of color to educate and test men and get the commitment from those doctors on board to make sure that we were going to follow through with any kind of care that was needed if anybody came back when somebody came back confirming a prostate cancer diagnosis. Further, we have a program that's called ZERO 360, which is a patient navigation program. As all of you out there who are watching this can imagine, when you're diagnosed with prostate cancer, it's a devastating piece of news. It's one of the most tragic journeys that you can go on in your life. And it causes not only an effect to your physical health, but it's a dramatic impact to causing financial and emotional distress. So our patient navigation program, ZERO 360, helps out prostate cancer patients, and about 25%, so 1 in 4 of men that we help through that program is a Black man. We need to do better there, but it's great progress to be able to reach into communities of color and offer that support. On the advocacy side, we have an initiative going right now that's called PSA for Him Act, and if passed, it will be a national passage in which every man who has an increased risk for prostate cancer, which includes African American men who have insurance, can get a test for prostate cancer without having a cost share, meaning that they don't have to pay any copay to get that done if we can get that initiative passed. So we're working with Congress with that right now. And also one of the most recent examples of some of the progress that we've made here is thanks to our advocates like Robert and like Phil. And I'm not kidding here, because both of them have put on their walking shoes and hit Capitol Hill and talked to elected representatives about this, but we successfully have increased the budget at the CDC and updated the CDC website to focus more on educating and empowering men of color to learn about the risk of prostate cancer and to know their PSA score and getting them the resources that they need.
Great. So I am very excited to be involved as the VP of Health Equity on all of those efforts. Robert and Dr. Moses, can you discuss any highlights from Zero's inaugural Racial Disparities in Prostate Cancer Symposium? Are there any moments that come back to you that you remember from that event?
Go ahead, Robert.
Okay. Yeah. Well, I think one of the biggest accomplishments, Dr. Seeley, is that bringing these men together and some women together on this task force, that was a huge step in that, it was a commitment to make a difference. And just by that gathering of people coming together to address the issues about clinical trials, for instance, and how we can get more African American men involved in clinical trials. One of the things that I remember us talking about during that conversation is that, and Dr. Moses probably will elaborate on this a little more, is that, for African Americans, participating in clinical trials was something that didn't show up on our radar screens too often. We have a history of practices with the medical community that left us shorthanded. And so that's a huge barrier that we have to get over. And what was interesting about the gathering of this group is that we realized that in order to move past that point, for one, you have to have safeguards there, to have more people participating in the trials, but also have people of color who are conducting these trials, who are involved in the research, because then that builds the trust level. And to that clinical trial participant, it's answered some of the questions like, okay, who's going to use this data? How is it going to help my community? And so I think the task force was really successful at coming up with a message that will communicate that to the African American community. And again, I think that was a major milestone in that we all wrapped our minds around that concept. And I think it will pay huge dividends as far as getting African Americans to participate. And one of the things I will add, what also was important to that discussion is we realized that when men and women, for that matter, know their why in life, now health becomes important. And so we can't treat prostate cancer, in this case, in a vacuum. We have to look at the whole man, if you will, to find out how we can help this individual do better in his community, through his network, and then his family. And I think by addressing health disparities as a whole, that's how we improve the community and improve the health of Black men.
Dr. Moses, any highlights from the symposium?
Yeah, I agree. Really the highlight, beyond any sort of specific moment, was really just a collaborative environment, that everybody was talking. We were able to address some concerns, dispel some myths, come up with some strategies. And so again, credit to ZERO and Jamie's leadership, and now you, Reggie, that it's really not just for show. This is really to try and get something done, to really try and help people on a grassroots level, but then on a much higher level, if we can advocate for, like Robert mentioned, clinical trial diversification, if we can help ZERO in its efforts to maintain funding for prostate cancer research and ensure that Black men are being included, that to me really was the highlight of the whole thing.
Yeah. And so both of you mentioned topics that I think are the pillars of the Racial Disparities Task Force that came out of that symposium. Do one of you want to tell our audience sort of what are the key pillars of the Racial Disparities Task Force?
Yeah, I can take that. So we sort of brainstormed, and just to give a little bit of background, the task force is composed of physicians, scientists, community advocates, men, women, Black, white. So we really wanted to have a diverse input on what we felt was important. And what we decided on the task force priorities, number one, education and awareness. And so that goes what I talked about, the grassroots level, and also on the physician level. So we want men to know about screening. We want men to know the statistics about prostate cancer. We want men to know about their options. But we also want physicians to understand what the disparities are, where they come from, and how to attack them. We mentioned clinical trial advocacy. Again, we want Black men to be represented and maybe even overrepresented in trials because of that mortality disparity, because of that morbidity disparity. We need Black men to be involved in the trial participation as well as trial design. And then lastly, financial assistance and patient support. And that goes back to what Jane was mentioning about ZERO 360, providing resources for patients to help pay for the cost of care, but then also patient support. And that's really important because there are true complications and side effects from treatment for prostate cancer. And men, sometimes we don't verbalize these things very well, but in a support group where there are other men who have gone through exactly what you've gone through, it lets you understand you're not alone in this. You're not the first person to deal with it, and give you strategies on how to maximize your survivorship. The vast majority of men with prostate cancer live with prostate cancer, or live, with the aftermath of treatment of prostate cancer. And so sometimes it's really important just to have someone else to walk that journey with you.
Robert, I think you're muted.
Reggie, I'd like to chime in for just a moment to ask you, what was it about ZERO that attracted you to come to the organization?
Yeah, that's a good question, Robert. So prior to joining ZERO, I was a professor. I conducted research and I taught courses focused on health disparities. My research specifically focused on financial hardship and cancer, specifically understanding how we measure financial hardship, its influence on outcomes across the prostate cancer or across the cancer continuum, from prevention to end of life care. And in my courses on health disparities, I always included discussions about systemic and structural racism, which is a focus on how discriminatory actions show up across our various systems, from our educational systems, our healthcare systems, our criminal justice systems. And I also spent a year in Washington, D.C. as a Robert Wood Johnson Health Policy Fellow, where I worked in the U.S. Senate, specifically in Senator Dianne Feinstein's office with her health policy team. And then my graduate training was in mental health and public health. I have a master's degree in counseling and family therapy from St. Louis University, and a master and doctoral degrees in public health from the Harvard T.H. Chan School of Public Health. And as a researcher, ZERO had been a research partner of mine. I added financial hardship questions to a survey with our ZERO 360 participants, and we've had poster presentations together at annual meetings for the American Society of Clinical Oncology, or ASCO, and at the Society of Behavioral Medicine meetings. So that's a bit about my background. Now, what attracted me to ZERO and to this position in particular? I think this past year and a half changed everything for many of us. The confluence of the COVID pandemic and the murders of Black and Brown folks by police last summer create a sustained conversation about systemic racism. And this sustained conversation encouraged me to think about how I could shift my work and focus on addressing racial and ethnic disparities in health. And given the substantial disparities that Kelvin mentioned related to prostate cancer, especially related to the disparities for Black men, this position at ZERO seemed like an amazing opportunity where my research background, my policy experience, along with my lived experience, would be a really good fit.
Wow, that impressive, and we are glad to have you, Reggie. You and I have talked before, and I've listened to the enthusiasm in your voice, so I'm really excited that you're on board, and I think you'll bring a wealth of knowledge and experience, and I think that will show through in the work that you'll produce for us. But I am so happy to have you on board. Jamie, did you have a comment?
I do. Speaking of what you're saying, Robert, of impressive and amazing and enthusiasm are all adjectives that I would use too. Reggie, a month onto the job of being a VP of Health Equity, we've talked just about every day, and each one of those conversations has been exciting and full of enthusiasm on some of the things that we want to do and are planning to do. And now, Reggie, we want to share some of that, of maybe some of these conversations that we've had together and with some of our partners.
Yeah, so I will share my screen to talk about what my plans are. Let's see here. Can everyone see that? See my slides? Great. Yeah. So my job as VP of Health Equity is to develop and implement the health equity strategy at ZERO, and to initiate and maintain partnerships to facilitate the reduction and elimination of prostate cancer disparities. And Dr. Moses mentioned the racial and ethnic differences in prostate cancer are stark. And my role here will be to lead efforts to address those differences and to work with partners to achieve health equity. To start this effort, I want to first highlight a framework that I developed based on my community-based effort and my research and teaching focused on health disparities. So in talking about my background, one thing that I didn't mention is I was also on the faculty at the Harvard T.H. I was on the faculty at the Harvard T.H. Chan School of Public Health. So that school is in Boston, but I lived in Rhode Island. And in Rhode Island, I served on a legislatively mandated commission that was focused on every 2 years writing the state level health disparities report. And I realized in writing that state level health disparities report that I had no idea how to write a state level health disparities report, even though I had trained in public health. And so I then thought, if I didn't know how to do it, and I trained in public health at Harvard, that our students probably didn't know how to do it either. So then I developed a course called Measuring and Reporting Health Disparities. And from that effort, I developed this framework for for what we went through in writing that state level health disparities report. And in all of my other efforts in working with community organizations, I realized that we all of those entities struggled with the same thing. That is, after deciding that they were going to focus on health disparities or focus on health equity, what next? There was really no pathway after the statement. And what's really interesting is that we saw that as well after this past summer with all of the discussions around systemic racism. So many organizations came out with, a statement related to systemic racism, but there was really no systemic or systematic path forward. And so with this framework, this is the framework that I plan to use here at ZERO to move our effort forward. And so the framework was adapted in a paper that I wrote. So I have the citation there. I wrote it with some colleagues, Dr. Sherry Flint Wallington, who's at George Washington University, Wei Zhao Tang, who's at USC, Beverly Cannon, who is a breast cancer advocate, and Dr. Drew McCoy, who's a geriatric oncologist in Chicago. And the framework begins with being explicit about definitions. That is, we often use these terms, health disparities, health equity, health inequality. We often use these terms interchangeably without being explicit about how we define these terms. So the first stage in the framework is be clear about your definitions. The next stage is, what are the health outcomes? What health outcomes are you focused on? So to say that we want to eliminate disparities in prostate cancer is a very big task. So where are we focusing? Are we focusing on prevention, detection, diagnosis, treatment, survivorship, end-of-life care? What are the specific outcomes we're focusing on? And then if we're reporting on disparities, what are the data sources? Where are we getting the data? And then how do we measure that difference? And the measurement part is important because there really isn't a good framework for when is a difference or when does a difference warrant action. And it's really this piece that in addition sort of motivated my interest in this position, because I would consistently go to conferences and you would see the disparities and people would talk about them and then move on. And I would wonder, where is the alarm? Black men are twice as likely to die from this disease. Where is the alarm? And so the challenge is there's really no threshold for action. How big does the disparity have to be? 1.5, 2 times? Does that warrant the alarm? And so I think it's really important to be very explicit about what is your measure of disparity. That is, when is a difference a disparity? Next is a focus on communication. Who is the audience for reporting those differences? If you talk to Black men, many of us are well aware of the differences and the disparities in prostate cancer. And actually, and as Dr. Moses mentioned, these differences are not just in prostate cancer. Many of us experience these differences across a myriad of diseases. And so it's important to be very clear about who is the audience that you are communicating your disparities to, and then who are the partners. So this is not a solo organizational effort. ZERO cannot eliminate the disparities alone. So we will have to find partners to work with to address this issue. And last, the importance of evaluation. That is, what does success look like? What does success look like in reducing health disparities and working towards health equity? So these are all questions and conversations that will be part of the implementation of a health equity strategy here at ZERO. In particular, how do we define disparities in the prostate cancer context, from prevention to detection, diagnosis, treatment, survivorship, and end-of-life care, to ensure that we are consistently working on putting an end to prostate cancer for all men. To implement this work requires an agreement of the definition of the problem. And without clear and agreed upon definitions, it's very easy to derail those efforts. So now I'm going to put up some definitions for some terms that we've been using throughout this conversation. So what is a health disparity? So the National Institute on Minority Health and Health Disparities has offered this definition for health disparities research, that a health disparity is a health difference that adversely affects disadvantaged populations based on one or more of the following health outcomes: higher incidence and/or prevalence and earlier onset of disease, higher prevalence of the risk factors or unhealthy behaviors or clinical measures in the causal pathway of a disease outcome, higher rates of condition-specific symptoms, reduced global daily functioning or self-reported health, related quality of life, using standardized measures, premature and or excessive mortality from diseases where population rates differ, and greater global burden of disease using a standardized metric. So I mentioned that this is a definition that's used for research. So it's going to be very important that we think about what is our definition for the work that we're doing at Zero in terms of how we define a health disparity. Oftentimes, health disparities and minority health are two terms that get conflated as well. The National Institute on Minority Health and Health Disparities also defines minority health, and they define minority health as all aspects of health and disease in one or more racial and ethnic minority populations as defined by the Office of Management and Budget. And this includes Blacks or African Americans, Hispanic Latinos, Asians, American Indians, Alaska Natives, and Native Hawaiians, and other Pacific Islanders. So the distinction here is a disparity is about the difference, and the minority health definition focuses on the health and the disease sort of outcomes in a specific racial or ethnic population. So what is health equity? So health equity means that everyone has a fair and just opportunity to be as healthy as possible. This requires removing obstacles to health, such as poverty, discrimination, and their consequences, including powerlessness and lack of access to good jobs with fair pay, quality education and housing, safe environments and healthcare. And so now you see why this is not something that Zero can do alone. This is something that we have to partner with many other organizations to do. But health equity is aspirational. It is what we are working towards. So how do we measure how we're working towards that aspiration? So for the purpose of measurement, health equity means reducing and ultimately eliminating disparities in health and its determinants. So the factors that contribute to those disparities that adversely affect excluded or marginalized groups. So as we implement the framework and we work through defining those terms for the prostate cancer context, I will also be working on building our health equity team here at Zero. And I've identified two specific projects to focus on, specifically focused on education and awareness. So I mentioned the course that I developed when I was at Harvard that focused on measuring and reporting health disparities. And in that course, we had a 3-part case study that would take students through the process of having to write that state level health disparities report. And I plan to adapt that to create a Health Equity 101, Health Equity 201, Health Equity 301, a toolkit or a primer to work with our individual partners and our organizational partners, first on defining health disparities and health equity for prostate cancer. And next, selecting prostate cancer outcomes to focus on. And then for 301, measuring health disparities. That is, when is a difference actionable? And I think these can help Zero and our individual and organizational partners be very specific about our efforts focused on health disparities and our efforts to achieve health equity. The second project that I plan to focus on is the development of a toolkit to help men expect an equitable cancer care delivery system. So the healthcare delivery system is starting to screen for patient social needs. That is, asking patients about their food insecurity or housing insecurity. So it's going to be important that men understand what's called the social determinants of health. Those are those social needs that impact how men are navigating prostate cancer care. And also focusing on education around clinical trials and reducing financial barriers to participation. So those are some definitions of health equity, my health disparities framework, and a few of the projects that I plan to implement in this new role. So now we'll see if there are any questions. Let me stop sharing my screen. Let's see, we have a couple of questions here. How are you working with other organizations? That efforts seem disorganized and without a strategic coalition. I think that's a great question. I am aware, I have collaborated with Finn in the past. As I mentioned, I lived in Boston. And so I look forward to partnering with other organizations in the effort, especially in the efforts of the education and awareness projects that I mentioned. Yes, so let's see, let's go to the next question. Oh, there's the stop. I was looking for the stop share button. There it is. Okay.
Reggie, if you don't mind, let me give a little bit more on that first question. So it's actually a great question because it's really relevant. You don't want a bunch of different people trying to do the same thing, or a bunch of different organizations trying to do the same thing. And what I would say is each one of these organizations, while they are prostate cancer focused, they have a little bit of a different agenda, which are not necessarily exclusive, but sort of like a Venn diagram, there are some overlap, but there are some unique contributions. I am on the board for ZERO, but I have also worked with Finn, and I also work with Prostate Cancer Coalition. And so you will see that a lot of the people who are involved, maybe in different organizations, Finn has been very much focused on community level education. They've also done some legislative advocacy as well. Prostate Cancer Foundation is very much focused on research funding, basic science, and clinical. And so I don't think that these organizations are mutually exclusive, but rather taking care of various spheres, all in the hopes of increasing education, funding, and awareness for prostate cancer.
That's right. Now, just add in very quickly, and I think we do a fairly good job of helping elevate each other, all three groups. Of if Fenn has a program or an activity going on, or we push that out through our website and our social media, and get it out there to people we're in contact with, or members of the prostate cancer community we're in contact with, and same with the Prostate Cancer Foundation of just trying to get those messages out there and try to make an impact together.
Jamie, I would also add that, what I find amazing about this space, if you will, is that there are no silos. While there are these different organizations, the common goal is to eradicate this disease. And you will hear that from anyone who attends a CF meeting or a FIN, you name it. And the common goal is to end prostate cancer. And so association almost comes secondly. But when these men and women come together to combat this disease, it's really about not running to different corners. It is about getting rid of the disease. And I look at it like this, that, sometimes you have a certain network that you like to watch, whether it's, the big three or cable or whatever. You want information, but you have these different opportunities to receive your information. And that's what I look at, how I look at these three organizations. But if you boil it all down, the common goal is to eradicate this disease.
Yeah, that's right. And prostate cancer organizations, we team up with some of our industry partners like Pfizer and AstraZeneca on many different programs, initiatives, and campaigns to be able to bring the message to communities of color. So we all are very much connected in that way too. And as Kelvin was mentioning, complementary, there's a little bit of overlap with that Venn diagram, but complementary of each other to be able to have a robust and deep campaign.
And as the VP of Health Equity, I look forward to working with all of those organizations. And our goal, as all of you have stated, if our goal is to end prostate cancer, and our goal is to do that in an equitable way. So that is that we don't necessarily eliminate prostate cancer for just one group, we eliminate it for all men. So I'd like to now talk about, or just to help contextualize health equity or health disparities. Can we talk a little bit about the importance of not only having a goal focused on health equity, but a strategy towards, implementation and dissemination. So can we talk about how folks have come together for our summit to talk about health disparities?
Was that aimed at me, Reggie? I'm sorry.
Oh, no. So I think one of the things that we wanted to talk about was sort of how everyone comes together for the summit. And so then folks come together for the summit, and then, you may talk about health disparities at the summit, but then how do those efforts then sort of go back into the community and are actually contextualized? I think that was something that Robert was going to talk about.
Yeah, well, the thing about the summit is that it brings people from all over the country together. And even with us going virtual last year, we had people from around the world actually joining us at some point. But what's amazing about the summit is that for the most part, it brings people from across the country together. And again, to focus on this one goal about eradicating prostate cancer. And what I can say is that because there is a collection of people from various racial backgrounds at the summit, the goal is to make sure everybody does and feels well. And you get that from the conversations that you have with all of the participants and the champions. But then we also supply information to the attendees that, here's how you go back to your communities and fight to end some of these disparities. And that's through workshops that we have. And then, some of the casual conversations that go on between different sessions. Where you have informal groups that will form outside of the ballroom or between a session. And so it really is empowering people to go back with a united message to end this disease, particularly in the African-American community. When we do the workshop, Dr. Moses and I do a workshop on health disparities, we address some of those core issues as to why we aren't showing up in the doctor's office. And again, it stems back to what we have learned about and what we know about. And one of the things that we focus on in that talk is to make sure that now go back with your why you want to live and how you want to elevate your community. And once you have that sense of empowerment, then you go back and you become the messenger in your community. And so that's what I find to be so beneficial, because there's also a conversation that happens, Reggie, throughout the year until the next summit. So they don't go there just for this summit and feel good and rah, 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 and maybe taking a couple of sites of DC. No, they go there to learn. They come to this event to be empowered. And so when they go back home to their communities, it's not a one-off. You hear from people throughout the year. And so that's what's really wonderful about the summit, is that each year you learn something new and something that has some legs that you can take back to the community. And so I think we do a really good job in talking about some of these core issues that need to be addressed and talked about in a forum where everybody is safe and you can talk and really express how you feel. And so it is no holds barred. Dr. Moses talks about, there was one example, Reggie, where he talked about, back in, I believe it was in the South, and Dr. Moses, you can correct me, but certain things that Black men experience that makes them have different viewpoints about the medical system and what challenges their manhood, if you will. So, prostate cancer is that man disease. And so typically we don't want anybody going below our waistline. And that is one of the barriers that men don't like. Black men have a problem with, is when you go to the doctor, it's like, oh, you know what? Is there any way you can test me without touching any extremity below the waistline? And so we talk openly about some of these experiences. And to dovetail back to what Dr. Moses talked about in one of the workshops, he said he can remember that there's a thing with Black men that you never touch their head. And Dr. Moses, I would love for you to elaborate on that. But, there are these certain cultural things that go on that lends itself to why we are skeptical about the healthcare system. And are there cultural things that diminish us as men? And so it's just such an enlightening conversation that you walk away and you begin to have a better understanding as to why. And that forum there gives us the framework to address those issues, so that when you leave that summit, you come away with a different mindset and you empower your community.
So, Dr. Moses, did you want to comment?
Yeah, I completely agree. Again, Robert hit the nail on the head. There are things that have been experienced in the Black community over centuries that inform how we act today. And a man may not know why, or may not be able to explain, I don't want you touching my head, or I don't want you grabbing me. But that is very much a cultural echo of a time where men and women were literally placed on top of a table or a box and poked and prodded by someone looking to buy them. And so your own personal agency, your own sexual agency is truly a direct outgrowth of a time where people had no agency over their own health. And it takes having what some people think are uncomfortable conversation, but really it's a conversation about truth, about what has happened in this country and how it reflects on today. And so again, I have to reiterate, the things that we see don't happen in a vacuum as far as prostate cancer or health. There are direct, verifiable contributions to why things are the way they are today. And one of the benefits of the summits is you do have people who come in with all kinds of different backgrounds, conservative, liberal, Black, white, short, tall, everything. And when you can get all these different viewpoints, but also find a common goal, a common background, that's when we'll be more successful. So we do have these conversations. As Robert said at the outset, this isn't a new thing for us. This didn't start after the events of last summer. This has been going on for years with ZERO. And again, that's a lot of credit to the leadership. And so, yeah, that the symposium is important, but it's about what happens afterwards when we get back to our homes, when we go speak to our Congress members. There are Congress people who I have not even wanted to enter their office because of their politics and things they've said. But I have to understand that there's a greater goal when it comes to legislative priorities for prostate cancer. And that's really where the benefit of the summit comes.
Mm-hmm. Mm-hmm.
And I look forward to when we're talking about the summit and having a whole track at the summit for years now focused on Black men and families and prostate cancer to come together to talk about some of the things that Kelvin and Robert just covered. But I also look forward to how we're going to be able to take those kinds of conversations, on the road, so to speak, across the country and be able to bring them to communities. So we're continuing that conversation outside of DC, outside of the summit that we put on every year, to reach more folks and to bring more folks into the ZERO community, so they can be a messenger, so they can be a prostate cancer champion or a ZERO champion to spread that word and to talk to others within the community, to get them to take ownership over their, feel like they have ownership over their own health and to be able to advocate for it.
Mm-hmm. And I look forward to sort of leading that charge and being the health equity champion here at ZERO, because it's important to highlight that a focus on health equity and health disparities, many of us may be hearing these terms more often than we've ever heard them, historically. But it's important to note that health equity, health disparities, these are not special topics here at ZERO, but will be something that will be a part of everything that we do. That is, my goal is that the health equity lens is a lens through which we view all of our activities. So in so doing, our efforts to end prostate cancer will ensure that we end it for all men, and not just for men who are in a specific racial group, not just for men who can afford it, not just for men who know someone at a specific cancer center, but for all men. Now, I recognize that this is hard work, and we want to avoid getting what I call equity fatigue. But if we all recognize that disparities in prostate cancer are hurting people we know and we love, And if we all work towards removing obstacles to good health for all men on the prostate cancer journey, we can make substantial progress on reducing and eliminating racial and ethnic disparities in prostate cancer and achieve health equity. So I know that we have only about 10 minutes left here, and we have a few questions in the chat. So I hope the group doesn't mind, but I'd like to sort of jump to the questions just to make sure that we give our town hall members an opportunity to get some of their questions answered.
Let's do it. You want me to take you through the questions, or do you want to?
Yeah. Yep, I have them open, so I can read them out. So the first question is, with only 3 to 4% of doctors being Black, and the leading reason that patients would consider and participate in a trial is that if their doctor asked or told them to do so, how do we drive other physicians and providers to change their attitudes and prejudices and encourage, motivate, and activate Black men to participate?
Yeah, that's a super important question, and that's kind of what we were talking about earlier in the task force, encouraging organizations to diversify their clinical trials. The way to get men to participate in clinical trials is really to follow the example by Nick Saban, right? How does Nick Saban get the best athletes from all over the country? Well, he's willing to go to any neighborhood at any point and speak with people directly to convince them to go to the University of Alabama. And if all these football coaches are willing to go to some of the most dangerous neighborhoods to get Black talent, why can't we do the same thing to help someone? Okay, we're not here to enrich ourselves. This is something where we want to, discuss directly with the community. And so there's a few things that we have to do. Number one, we have to encourage cultural competency amongst all physicians. We have to encourage diversification of the physician cohort. And we have to encourage, when we talk to the Congress people or to the various companies that want to be sponsors, we have to hold their feet to the fire and say, hey, how are you ensuring that Black men are equitably represented in this trial, not only in its conduct and design and participation? Same thing with companies. Hey, you want to partner with us. What is your strategic plan for inclusion of diverse population within your clinical trial? So that's the hope of the task force and my personal mission when I go out and speak in various medical organizations. I bring in that historical aspect so they understand why it's important that why these disparities exist, but then also why it's important to help eliminate them.
Mm-hmm. Mm-hmm. I'd also like to add for the education and awareness tool that I mentioned, where we are planning to create a toolkit to help men expect health equity in the cancer care delivery system. My goal there in building that toolkit, part of the process will be to talk to patients, but to also to talk to providers. I think as Dr. Moses mentioned, sort of, I don't think any provider sort of assumes that they are not delivering, equitable care, but I think they need to be educated on what equitable care looks like. And so hearing from providers on their notions of what cancer care equity means to them in their practice, but also talking to healthcare systems. What do healthcare systems think a cancer care equitable system looks like? Because I think that's going to be important to think about it from the perspective of the patient, from the provider, and also from the system level. Let's see. Any other comments on that question? Okay. The next question is, why can't prostate cancer tests be prioritized for men the same way that pap smears are for women? Women are encouraged to have yearly annual checkups, so I would think that men should be encouraged to have it checked at their annual checkups every year as well.
Yeah, so that goes to some of the controversy about prostate cancer screening. So the PSA test when it was initially introduced in the late 80s, was really meant for following along men who have prostate cancer or who have already been treated for it. It was never really designed to be a screening test. And so it never underwent a true randomized trial early on to determine if it has survival benefit or not. Over the years, we have seen that it has a survival benefit, but it also led to what's called lead time bias, meaning that many men were diagnosed with non-fatal cancer at early stages and were probably being overtreated. And so at around 2010, 2012, the United States Preventive Services Task Force actually gave PSA screening an F. They said, do not screen. And over the years, there have been some studies, both in the United States and in Europe, that looked at screening and probably were published a little bit too early, and there were some issues with the conduct of those trials. But as time has gone on, the ones that were done appropriately, particularly in Europe, have shown a survival benefit. And on the other side of it, physicians have recognized that not every prostate cancer has to be treated. Because PSA is a non-specific test, in comparison to a pap smear, that's a direct test. You can look directly at cells. Is there cancer or not? And so that's where a little bit of the controversy comes. All of the guidelines panels that discuss screening for prostate cancer, including now USPSTF, say this should be a shared decision-making model where patients and physicians discuss the risk and benefits of screening. And then also we encourage active surveillance for patients with low-grade cancers that otherwise would not be fatal. And I think that, the pendulum swung a little bit too far in the no screening category. And I think we're getting closer to a happy medium where we're screening the appropriate people, we're treating the appropriate people, and also avoiding treatment in those who don't need it.
Great. So the next question is about the framework. It says, should it not be earlier to build coalition and optimize community engagement? Most definitely. Building partnerships are going to be part and parcel to what we do. And actually, in building the health equity team at ZERO, the first staff member that I'm looking to hire will be the person who will help me do just that.
That's great. We also got some comments in along with the questions, and I wanted to throw them to the three of you. One person says, no question, but bravo to the three of you for working on a Disparities Program initiative and implementing it. And that comes from us to support group leader, which is great. That's another area in which we collaborate very well in to be able to reach men and families of color through support groups. It's absolutely critical that we have that support structure and that mentor-mentee relationship to help prostate cancer patients, not only of color, but then also going back to what Robert talked about at the outset of, in some respects, it doesn't, color doesn't matter. It can come down to ebony and ivory of, it doesn't matter about the color of our skin. We're here to help each other get through our prostate cancer journeys together so we can go on and have happy, healthy lives. Another thing, another comment that got shared was a PhD student at Case Western says that they're working on prostate cancer, and we're learning about frameworks and clearly defining our terms in our classes. And I thought that Dr. Tucker-Seeley did an excellent job with this. So I just wanted to pass those comments on.
Thank you. Thank you. Thanks. Oh, that's nice. And I think one of the key themes that we're hearing here today is the importance of providing spaces for men to talk about things that they may not have other spaces to do that. So whether it be the summit, whether it be our racial disparities symposium, whether it be our support groups, sort of one thing that I think that ZERO does really well is sort of creating these opportunities for men to talk about these issues that they may not have other spaces in which to talk about them, but then to talk about them in the summit and then take them back to their respective communities is I think a key component of the many programs that we provide here at ZERO. Let's see. How do organizations reach out to you? So going to our website. And as Jamie mentioned, we have a mini site, which is zerocancer.org /racial disparities. And that provides a lot of information on our Racial Disparities Task Force. And also at zerocancer.org, there are also places to find all of our resources. But if you're looking to reach me directly, my email is reggie@zero.org. Have you considered outreach to barbershops, hair salons for reaching African American men? So there are several research studies focused on barbershops and hair salons. Our goal at this moment now is we're building a health equity partnership list that includes individuals and organizations. And so in building that list, we are looking for partners in communities that will partner with us to focus on health equity. So we're open to barbershops, hair salons, any place where those partnerships can be developed. But we're also interested in sustained partnerships. So one of the things that I back in from my days as a researcher, what I don't want to do is to be considered, it's called it being a helicopter researcher. So you get the funds, you fly into the community, you do a little bit of work. When the funds are over, you fly back out. And that's not what we want to do here. We want to make sure that we are creating sustained partnerships. So we are a little over on time. So
I was just going to say that, as far as barbershops go, I think that's a great idea, since it looks like all four of us go to the same one.
Yes, the barbershop at home. Yeah.
We'll start our quartet going.
That's great. That's great. So we're a little over time. So Jamie, I'll hand it back over to you.
It sounds good, Reggie. I just want to thank our sponsors again, Pfizer and AstraZeneca, for helping us bring this town hall together. And I especially wanted to thank you, Reggie. I look forward to working together with you to make a difference and continue to work shoulder to shoulder with Robert and Kelvin. Thanks for making time today and coming together for a great town hall. I just want to reiterate, and I said this at the outset, our mission is in our name: zero the end of prostate cancer. We cannot end prostate cancer without zeroing out racial disparities. And putting an end to prostate cancer means putting an end to prostate cancer for everyone. So we all over can create generation zero, that first generation of men who are free from prostate cancer. And that goes for all racial groups. So again, thank you for joining us. Thank you for all of our participants and all the great questions and comments too. Thank you and have a wonderful day. Thank you, gentlemen.
Thank you for having me.
Thank you.